So the mutations that we found, obviously, when you have such a limited cohort, using just a genome cohort, it's difficult to provide evidence of something, let's say, mechanism of resistance. Looking at a larger cohort, like the COMPASS dataset, you can identify mechanism of alterations that are recurrent, so present, let's say, more than 1% of the patients using, again, complex mathematical approaches. But after all, none of these events are strongly associated with treatment response. So the idea that is progressively coming out in our team is that the recurrent event, or what we call recurrent, what we say the most obvious, the one that everyone, including us, have been looking for, are mostly involved in the pathogenesis of the cancer. But for the treatment response, there is something that we are missing. And it's probably something extremely rare, extremely specific for each single patient, and maybe not even connected to the cancer cell. Maybe it's the microenvironment, the background, the patient's predisposition. So there are many factors that should be accounted for. I'm not sure that whole genome sequencing is the only explanation. So probably we need to integrate whole genome sequencing, RNA sequencing, analysis of the microenvironment, immunological profile of the patients, and obviously also pharmacocinetic and dynamic studies in order to see if maybe it's the treatment the problem rather than the cancer.